Good evening, everybody. Very nice to be here tonight with you, and thank you for the invitation to present neurogenic bladder in children. I'm a urologist at Boston Children's Hospital, and I direct the Spina Bifida Center. So this is a topic that is certainly near and dear to my heart. I have no relevant disclosures. So we'll discuss spina bifida, some definitions, the causes, the care, and then neurogenic bladder more broadly and generally. And beginning with spina bifida, this is also known as myelodysplasia. We have really tried to get away from that word. Myelodysplasia is a hematological disease, as told to me by my hematologist spouse. And so spina bifida is what we prefer these days. It is a developmental birth defect caused by the incomplete closure of the embryonic neural tube. This happens pretty early on, 4 weeks gestation, and it is the failure of the neural folds to fuse in the midline and to form a neural tube. Because of this, some of the overlying vertebrae are not formed and therefore remain unfused, and this produces an opening. And if the opening is large enough, you get protrusion of the spinal cord and spinal nerve roots through the opening. And here's a cartoon illustrating that concept, where this is what is supposed to happen. You have the neural tube, the neural folds, the invagination, and then the complete neural tube formation with the overlying epidermis. So there are basically two types of neural tube defects in a broad sense. The first are the open neural tube defects, where you have exposed neural tissue. And in the worst case, you have anencephaly or total failure of neurulation and spina bifida cystica, which comprise meningocele and the most common myelomeningocele. Then we have closed neural tube defects, such as encephaloceles, split cord, and spina bifida occulta. And so this is just an illustration of the types of spina bifida. The myelomeningocele, once again, is the most common, and it is the most severe phenotype. And here you see that defect, that vertebral defect with the protrusion of the spinal cord and the spinal nerve roots through this very large opening. The meningocele is the least common. It's protrusion of just the meninges without spinal cord or spinal nerve roots. And finally, spina bifida occulta, which is really common, 10 to 20% of healthy individuals. And this often is diagnosed on plain films done for another purpose, where there'll be some anomaly of a vertebral body, an extra process, so on and so forth. And by and large, these patients don't have underlying neurogenic processes. So this is a picture of one of our newborns with the spina bifida defect that has not yet been closed. This patient is in the operating room about to go closure. That's why he is in the prone position. So the incidence is 1 to perhaps 0.7 per 1,000 US live births. It is the most common permanently disabling birth defect, and it affects roughly 8 babies per day in the United States. It's unclear how many pregnancies are terminated, and of course, this is very likely regional. On the East Coast and West Coast, this is likely happening more often, and in the Midwest and the South, less often. There is variability amongst ethnic groups, with a higher incidence in Caucasians and in Hispanics. And the highest incidence, at least historically, was in the immigrants from Ireland. The male to female ratio is 0.82, and there's a 2 to 6% recurrence risk into siblings, or a 50-fold increased risk. And so we get this all the time from families that have a child with spina bifida. So this is a good number to remember when you're seeing these patients in clinic. And then there's a 4% recurrence risk in offspring of patients that they themselves have neural tube defects. One would think it would be higher than that, but it is actually quite low. So what are the causes of spina bifida? So 95% of neural tube defects occur in pregnancies with no personal or family history of neural tube defects. It's likely multifactorial, like most things. But it can be syndrome related. A good example is the Vactral Association, which brings a risk of spinal dysraphism, which can be considered under the umbrella of spina bifida. Chromosomal specific abnormalities represent only 2 to 16% of isolated neural tube defects. That number is likely to change as we get more and more robust genetic data as studies continue to be done, but that is the present understanding. There's a 7.7% concordance for monozygotic twins and a 4% concordance for dizygotic twins. There is an association with maternal obesity, specifically a BMI greater than 30. And this is sacral agenesis specifically, and thought to be also related to gestational diabetes. So mothers with gestational diabetes, obesity is a risk factor for that, especially if they're on insulin, have a higher risk of having fetuses with sacral agenesis. So maternal drug exposure, including folate antagonists, anticonvulsants have been linked, again, IDDM, and then possibly Agent Orange exposure in fathers, not well understood, but a unfortunate possible cause that was related, of course, to the Vietnam War. So how about folic acid? Why is that so important? We hear this all the time in the context of spina bifida. So since the 1700s, there has been a relationship between social class and the prevalence of neurotube defects. In the 1960s, it was first suggested that low folate status was a specific risk factor for neurotube defects. For several decades, data were derived from case reports. And in 1981, Lawrence and colleagues first reported a randomized controlled trial. In 1991 was the MRC UK trial, which was the first large multi-center randomized controlled trial. And they compared 4 milligrams per day of folic acid versus a multivitamin versus a placebo, and saw a staggering 72% reduction in neurotube defects. Talk about moving the needle, really important seminal work. Subsequently, there have been clinical trials done in Budapest and in China. The mechanism of folic acid still remains not clearly understood. And these countries that are shaded are those that have folic acid food fortification. So the majority of the developed world certainly, but still you can see all of Europe actually does not have folic acid fortification, which is surprising, and then a lot of the Asian countries. So this is what the world looks like. Spina bifida is a multi-system condition. It affects basically everything. So you have risk of spinal defects and of course spinal cord tethering. 80 to 90% will have the Arnold-Chiari 2 malformation involving the brainstem. 80 to 90% have hydrocephalus, paraplegia or impaired ambulation, scoliosis, and other severe orthopedic deformities are quite common. Seizure disorder, latex allergy, precocious puberty from central nervous system dysfunction, a characteristic neuropsychological profile of being, having significant challenges and disabilities, and of course, neurogenic bowel and bladder. So a little more history. This is at least in the United States, a very important case, and it's of the baby Jane Doe, who was born on October 11th, 1983 in Port Jefferson, New York. She was found to have myelomeningocele and hydrocephalus, and the parents were advised, again, this is 1983, I was in middle school, for heaven's sakes. Parents advised that she would die without surgery, but with surgery, she would live 22 to 20 years, be paralyzed, bedridden, incontinent, and severely, quote, retarded. And this was just written in the literature. Not that we would ever use that terminology now, of course. Surgery was withheld, resulting in encephalomeningitis, and then litigation subsequently and media coverage focused on the, quote, quality of life. So prior to 1960, their survival rate was very low, 10 to 12%. And this case really brought spina bifida into the national attention. Surgery was generally postponed until 2 years of age, specifically because only the strongest and therefore those with the best prognosis would survive that long. And so selection of those that could actually survive the lesion was the thought. And the practice of selective non-treatment was thankfully largely abandoned by the late 1970s and early 1980s. And so really pretty recent when you think about it. Again, multi-system condition really, again, involves everybody: developmental pediatrics, neurosurgery, orthopedic surgery, urologists, endocrinologists, pulmonary specialists, nephrologists, neuropsychologists, GI nutrition, plastic surgery, and social work. And at Boston Children's Hospital, all of those specialists are represented in our Spina Bifida Center. This is just our Facebook page. It's a very small portion of the team. But we couldn't get everybody in one picture. But just to say, it absolutely takes that kind of village. And this is just another picture of our team, who are just absolutely wonderful. So neurogenic bladder, now that we've covered spina bifida, is the dysfunction of the bladder due to diseases of the central nervous system or peripheral nerves involved in the control of micturition. There's a variable phenotype from a small capacity bladder that has overactive contractions and impaired compliance, or high pressure stiff bladder, to one that is large capacity and areflexic, so holds a lot of urine, low pressure, just doesn't contract well. And some measure of external urinary sphincter dysfunction is also a part of the phenotype. Consequences include incontinence, urinary tract infection, and renal damage or failure in the absolute worst case scenario. And one can understand why this is variable, because the innervation of the bladder in the lower urinary tract is very complicated, as we all know. We're not going to spend a lot of time on this, but of course, just to highlight that the innervation, the function of the lower urinary tract involves the sympathetic system via the hypogastric nerve, the parasympathetic system via the pelvic nerve, and the somatic system via the pudendal nerve. And all of these are tightly orchestrated to produce safe storage and safe, efficient voiding. And when things happen, that tightly controlled, orchestrated response can be thrown off. And so I'm going to basically talk about levels of lesion and then talk about who, what happens, and then what results. And so when you have a brain level lesion, so who gets brain level lesions in pediatrics? Well, patients that have strokes as infants, especially premature infants, tumors, trauma, hydrocephalus, cerebral palsy, and other rare, thankfully rare illnesses such as Shy-Drager, etc. And so what happens? You have interruption of the pontine micturition center, which resides just right around here in the pons, and you have preservation of the spinal cord and sacral reflexes. So when you put that together, what happens? You have neurogenic detrusor overactivity because your pons is firing and you don't have that inhibition. But the sphincter is coordinated because you have preservation of the spinal cord and the sacral reflexes. So these are patients with NDO, neurogenic detrusor overactivity. How about spinal cord level lesions, specifically suprasacral level lesions? Well, these are patients that have trauma, tumors, infection of their spinal cord, ischemia from a variety of different sources, spina bifida, and MS, multiple sclerosis. So what happens, you have a variable interruption of the communication between the sacral cord and the brain and the sympathetic, parasympathetic, and somatic systems. Again, thinking about that graph where you have this highly complicated innervation picture. What results? Typically speaking, NDO, or neurogenic detrusor overactivity, again, because of interruption with the brain and the pontine micturition center not being activated. And you get sphincter dyssynergy because you have an interruption of the communication at the spinal cord level. So how about sacral spinal cord lesions? Again, tumor, trauma, infection, low-level spina bifida. And so what happens here? You have interruption of the parasympathetic or pelvic nerve and the somatic pudendal nerve system. So very far down. Here you get detrusor underactivity with an acontractile bladder and a sphincter with minimal function, denervation, and fibrosis. Again, because of that pudendal nerve specifically. And again, it makes sense because parasympathetic is the system that results in bladder contraction. And when you interrupt that, you can't contract and you get sort of this over-relaxed acontractile bladder. So how about the special case of lesions above T6? We get autonomic dysreflexia. This is something that for trainees really should be emblazoned in your cortex for in-service questions. It is due to an exaggerated and unopposed sympathetic response to stimuli below this T6 lesion. It's often seen in patients that have C-spine lesions, such as MVAs, so on and so forth, spinal cord injuries. It is associated with hypertension, reflex bradycardia, headache, perspiration, and flushing. And if you haven't seen this, it is quite impressive. These are patients in whom you're doing a cystoscopy, for example. You put in the scope, start filling the bladder, and you get all of these responses, which are quite frightening. And the treatment is rapid decompression and and vasodilating agents that your anesthesiologist or others can help you with. But pretty impressive when you see it. Something to keep in mind when you're manipulating the lower tract of patients with C-spine injuries, specifically above T6. So this is what a neurogenic bladder looks like, at least the ones that progress to this so-called Christmas tree appearance. Looks like a Christmas tree. It's a triangle and it has all the shagginess. These are cellules and diverticula, and here's some reflux as well. And so this is what we're hoping to avoid. And so the causes of neurogenic dysfunction, we opened with spina bifida. That's for good reason. 95% of neurogenic bladders are caused by spina bifida, of which open neural tube defects comprise the majority, 85%. Sacral agenesis at 3%, spinal cord injury, thankfully, these are always devastating cases, 1%, and then the associated anomalies that we discussed, such as the VACTERL association, is also about 1%. So what do we do for patients that are newborn with a diagnosis of neurogenic bladder? So these are patients, I say AFCC, that's an internal moniker to Boston Children's. It's the Advanced Fetal Care Center. So these are maternal fetal consults. And so we're often called at that point, which I'm very thankful for, because we can start counseling families early on. And so what do we do in the newborn? Well, generally neurosurgery gets involved immediately, and plastic surgery sometimes helps them close the back defect. They may get a VP shunt. Here, patients get something called an ETV CPC that was pioneered by my neurosurgery colleague, Dr. Ben Wharf. And he was a missionary in Uganda, actually, and developed this procedure, for which he won a MacArthur Genius Award. And he's a wonderful, wonderful colleague. And anyway, it's a way around leaving VP shunts. But let's say the hydrocephalus should be managed. And then we're consulted for the initial evaluation of the bladder and kidneys. So generally we leave a Foley catheter until the back is closed, until the patient recovers. After the Foley is removed, we generally get a post-void residual as best we can. Bladder scans are very difficult in the newborn, so we basically start with clean intermittent catheterization about every 4 hours, just as a matter of course. And over several days, you'll get the ability to sort of measure, assess how well a patient is emptying their bladder. If the residuals are low, then we go to CIC Q6 hours on the way to stopping it. If the residuals are high, we teach the family how to perform intermittent cath and then send them home on intermittent catheterization. And we always get a renal and bladder ultrasound before the patient leaves to be sure we're not missing any upper tract issues for which we need further workup before we send them home with their families. We generally get then an outpatient workup for the urology piece, and that includes a urodynamic study. I discussed urodynamics yesterday at the COVID lecture series. And so here at Boston Children's, we use the moniker full urodynamics. That basically just means a urodynamics with a cystometrogram and a sphincter needle EMG. And the point is, whether it's a sphincter EMG needle or it's a patch, video urodynamics, whatever it is, the point is to get the most complete assessment of the child's lower urinary tract. And we like to do it as early as possible, 2 to 3 months. We get a VCUG if we see abnormalities on the ultrasound, or if the urodynamics show DSD, detrusor sphincter dyssynergy, or we have hostile bladder dynamics. We'll get the VCUG. What are the importance of urodynamics? For us, they're critically important, and they provide a baseline assessment of lower tract function, including sphincter innervation. It allows us to track progressive changes in function or innervation. It also enhances parental counseling regarding the future of lower tract function, and certainly guides our medical and surgical management. And we do this quite a lot. We generally get urodynamics about every 6 months for the first 2 years of life, then yearly until 5. And then after that time, more of an individualized basis. And we stick to that with most patients. The components of urodynamics briefly are all of these. Uroflowmetry in the patients that can void spontaneously. Obviously, we're talking about urodynamics in babies. We're not getting uroflowmetries. Post-void residual, CMG. We assess leak point pressure. The pressure flow study to assess, voiding pressures, etc. if a patient's able to void. An external sphincter EMG. Again, patch electrodes versus concentric needle electrodes. Not a lot of places have needle electrodes. We do, and I can't tell you how important it has been for our practice. and finally video urodynamics. So these are the highlighted ones are the ones that we generally do. We do not do video urodynamics at Boston Children's, and the main reason is just historical. We didn't have the facilities, and we don't have a fluoroscope with which to do urodynamics. And so, but that will be something we will do in the next several years when we have a new facility. So this is what our study looks like, basically in a little baby with a neurogenic bladder. The needle is placed directly into the external sphincter in this little girl, and little boys is placed in the perineum. And as that electrode is placed, we place catheters in the bladder, a rectal catheter per routine, and then monitor, of course, bladder pressures, rectal pressures, and then subtract rectal from bladder to get a detrusor pressure. Then we monitor simultaneously the electromyography, the EMG potentials from our concentric needle. And from that, we get a ton of information, which I'll get to in a second. So for the systemetrogram component, these are the parameters that we get. An opening pressure, so we put the catheter and basically ask what is the opening volume and what is the pressure at that volume, trying to get the most physiologic data that we can. Again, we get a detrusor pressure by subtracting abdominal pressure from vesical pressure. We try to document bladder sensation first versus when a patient feels full, document if there is detrusor overactivity, and of course there are definitions for all of these. Document max detrusor filling pressure, calculate compliance as volume over pressure, determine the detrusor leak point pressure, which is defined as the lowest pressure at which urine leakage occurs in the absence of a detrusor contraction or increased abdominal pressure. This is what the EMG data look like when we print them out. And these are what normal motor units look like. Our newest faculty member, Scott Wang, is a phenomenal urologist that just finished our fellowship. And he is training in our urodynamics facility, but also we're sending him to the BI Deaconess across the street to train with adult neurologists who are neuromuscular specialists to really get this expertise, because currently we're doing these studies with a neurologist, but we feel that we really need to do this ourselves. And so we're trying to become expert in EMG, which is quite interesting. The big thing we're looking for are fibrillation potentials, which is an early sign of denervation. And so these are the big ones. When we see fibrillation potentials, we tell our neurosurgeon, there is evidence of denervation, i.e. we think this child's spinal cord is retethering. Or we see a significant sudden worsening of bladder dynamics, same thing. But these fibrillation potentials seem to be the most sensitive readout for something happening at the level of the central nervous system. And then polyphasic potentials here we see as what a polyphasic potential looks like, and that's evidence for reinnervation. Or if there's inflammation. So if a child had a recent UTI, we often see polyphasic potentials. If they had their spinal cord untethered and their recovering function, we will see these polyphasic potentials. So this is what these things look like in combination. So when we have a nice study that is normal, so sphincter synergy, we can see the bladder is filling. Again, we're subtracting abdominal pressure from bladder pressure. We're filling. The patient voids. And if we look at the simultaneous EMG, there's complete silencing of that signal, i.e. patients relaxing their sphincter, and they are therefore synergic. This is a dysynergic patient. You see some bladder overactivity here as well, very common neurogenic phenotype. And then there's this large contraction, and the patient never ever silences their sphincter. So this is a patient that is dysynergic. Now, I will say parenthetically that if you were monitoring sphincter activity with patch electrodes, the fear is that you're going to pick up muscle activity from the pelvis at large and that you can't hone in on the sphincter itself, and that is true. So it's still useful for sure, but doesn't really give you that ability to discriminate specifically for the sphincter activity, and of course, also the ability to discriminate fibrillation potentials from normal motor unit potentials. Then we test a whole host of sacral reflexes, bulbocavernosus, anocutaneous, Crede, and a Valsalva, and monitor these. This is more for change. So as we repeat these studies, if there's a significant change in these, that also raises our attention to possibly something happening at the level of the spinal cord. We can also use these sacral reflexes, though, interestingly, to predict certain things, such as erectile capacity, whether a patient is going to be synergic, and whether there's going to be detrusor stability and contractility. And so all of these things inform those different things. And the ones that we find the most useful really is erectile capacity. So interestingly, the positive response to the Valsalva maneuver predicts most closely erectile capacity. So we do use this clinically, and quite powerful. So how do we interpret urodynamic studies in patients with neurogenic bladders? What's a happy bladder? What's an angry bladder? And basically, and how does that influence our management? So this is a paper that came out from the group that is involved. It's expanded now, but originally we're involved with the National Spina Bifida Patient Registry, the CDC centers. And basically, these protocols were written to standardize the management of newborns with myelomeningocele across multiple participating centers. And the secondary objective was to determine adherence to the protocols, determine if the protocols were optimized to maximize urological function and minimize morbidity, and to characterize protocol deviations in cases, and then to better define the longitudinal impact of spina bifida on bladder and renal function. And so patients get urodynamics, renal and bladder ultrasounds, GFR, and renal scarring specifically with the MSA scan. And the outcomes included urinary tract infection, hydronephrosis, scarring, blood pressure, GFR, and urodynamic findings. Importantly, we use this a lot ourselves because we're an NSBPR center, but I also find it useful at least to standardize in the literature, and that is the definition of a hostile bladder. And in this paper, it was defined as a bladder with an end filling pressure or detrusor leak point pressure of greater than or equal to 40 centimeters of water. And everybody should know that that's based on Dr. McGuire's data from 1981, also a classic question that everybody gets asked. A hostile bladder was also defined as neurogenic detrusor overactivity with detrusor sphincter dyssynergy. And to me, really, what this speaks to is the importance of doing good urodynamics. At the end of the day, if you're going to define a hostile bladder, which is obviously, the bottom line for our patients, we have to be able to do good urodynamics. This is just a screenshot, basically, of the workflow for these patients, the protocol that was published, and we do try to adhere to this again as closely as possible in all of our patients. And we're of course very hopeful, like all centers, that this will yield rigorous and robust research that can be used to figure out the best way to manage our patients. So at BCH, how do we manage bladders? Well, for non-hostile bladders, we're going to define those as, those bladders that have normal capacity, they have low pressure, minimal detrusor overactivity, and a minimal residual volume. We generally observe these patients and allow volitional voiding. Of course, we're keeping a very close eye on these patients, and so we try not to start intermittent catheterization or medication if a bladder meets these criteria. A hostile bladder, we use, again, per the definition of the CDC, NSBPR, and in these patients, we start CIC and anticholinergics when we make that diagnosis, i.e. 1 to 2 to 3 months of age. And in general, our anticholinergic of choice, of course, is oxybutynin. And we generally started, this is something that goes back to my colleague, Dr. Stuart Bauer, who's been doing this since the 70s. And for decades, he has done basically 0.1 milligrams per month of life, up to about a milligram. When they're 10 months, then we continue. And patients tend to tolerate this well. That is completely off-label, obviously, but that is what we have been doing, again, for decades. And clean intermittent catheterization is the other cornerstone. And the importance of CIC cannot be overstated. Of course, this is owed to Dr. Lapides, and it seems so simple, but it really is quite revolutionary. And the mechanism of why it's so important is that it bypasses this dyssynergic sphincter. So as that bladder is contracting, especially if you have that NDO, neurogenic detrusor overactivity, contracting against a dyssynergic sphincter, you're generating very high pressures. And those pressures, as I describe this to our patients, are exercising the bladder, right? So you get a strong bladder who's stiff and remodels pathologically. So deposition of collagen, a fibrotic phenotype, and all of that traps patients in vicious cycles. So you bypass that entirely. So we tell families we need to convert your bladder into an efficient storage reservoir. We do not want it to contract. We do not want it to do anything except hold urine. And this can be a tough sell because families are going to tell you, but we saw him or her void. We know urine is coming out. They're wet diapers. What do you mean you don't want her to? She can, she does. And so you have to spend a lot of time and work and effort to really educate your patients so they understand the why, because the why here is everything. And so basically we end at, just because they can void, it doesn't mean they should void. And I think that generally helps. But I will say it takes sometimes 2 and 3 and maybe 4 conversations before families really understand this important concept. It is tough to accept that your child needs intermittent catheterization, and it is difficult to do, especially at the beginning. So, but anyway, it is super, super important. So it bypasses the sphincter, it achieves complete emptying. The positives are, of course, allows a patient to possibly achieve continence, and it preserves renal function. The cons, of course, associated with risk of urinary tract infection, catheter-related trauma, especially in boys, and then physical limitations, children that have difficulty doing this for whatever reason for themselves. And so how about anticholinergics? Of course, we give those to abolish overactive contractions, to increase bladder capacity, lower those storage pressures. And again, oxybutynin is our go-to in liquid form. We also compound, though, tolterodine, also trospium we compound. I have been using mirabegron on an increasing basis, and a new beta-3 agonist. Maybe some of you have experience with it in the adult world or in pediatrics. I will say, and we hope to publish on this soon, I'm sure others are working on this too, we have avoided probably now a good 6 or 7 augmentation cystoplasties because of the effectiveness of mirabegron in combination with anticholinergics. Quite impressive. So we're very happy, and our patients and parents are very happy about this too. Botox can be used as well to abolish overactive contractions. That is the specific indication, certainly in neurogenic bladder in adults. And it is effective for overactive contractions. We have not found it to be particularly effective in patients that have fibrotic bladders who have very high storage pressures, the end stage bladder, so-called. We don't use this a lot, I will admit, because in our hands it requires general anesthesia for repeated infections. And to us, it's hard to relegate a child at, say, 2 years old to an entire childhood of repeat re-injections at a certain cadence. And so we generally don't use Botox very much in the pre-adolescent age group. So in the first 2 years of life, like I said earlier, renal and bladder ultrasound and urodynamics about every 6 months. Between 2 and 5, ultrasound and urodynamics yearly. Older than 5, an ultrasound yearly. Urodynamics based on change in symptoms or change in medication. That's really an individualized thing. We encourage early self-intermittent catheterization. Of course, manage their recurrent infections if they have vesicoureteral reflux, stones, incontinence, et cetera, et cetera. So all of this gets individualized as the child ages. Update on the guidelines. Basically, the Spina Bifida Association published this wonderful guidelines book, 247 pages, wonderful collection of expert opinions. I have this on my desk and reference it all the time. Very, very useful. We have two docs at Boston Children's that participated in this, our nephrologist and our clinical psychologist. We're very proud of their contributions. And anyway, this is just a reference that I think everybody should know about and certainly reference in the care of our patients. And these are, of course, the primary aims: maintain normal renal function throughout a lifetime, achieve continence as early as socially acceptable, maximize independence, and then secondary is eliminate these hostile dynamics through medical management, reduce or eliminate operative reconstruction of the bladder. This is so important, especially this day and age when we understand the complications associated with augmentation cystoplasty. Maximize renal outcomes, reduce the impact of urinary tract infection and antibiotic overuse, and establish a program that promotes urologic independence. And there's some tertiary aims as well. And so these guidelines between 0 and 11 months old, and again, I show you these because they are more specific than what we were doing at Boston Children's Hospital before we started into some of these protocols. And so you can see these. I'm not going to go through every single line item here, but just to say that the guidelines are very, very specific, by year, by age group. And again, everybody I think should be referencing these and using these at least as a starting point to guide the care of patients with spina bifida and neurogenic bladder. So how about surgical management? Well, we have about 10 minutes to cover some of this. I hope to get through most of it. Surgical management really is reserved for patients that have failed maximal medical therapy. Patients that have markedly decreased bladder capacity, intractable hyperactivity or hyperreflexia, intractable incontinence, difficulty catheterizing on either an anatomical or functional basis, or they have upper tract compromise. And some patients are unlucky enough to have several of these. So how about when we're trying to improve bladder storage function? The options are here, but not really. I include these really for historical purposes. Auto augmentation, nobody does this or should do this. Ureteral augmentation can be done. I've seen one case, very rare, to have leftover ureter enough to augment the bladder, but when you can, boy, is it nice. Enterocystoplasty is really the standard, using ilium as the preferred segment or colon as the second preferred. Stomach has been largely abandoned, secondary to concerns around cancer. I have done a few augments early on. As a fellow, I did a few. As a staff member, I've done one. It is a delight to work with stomach. The tissue is amazing, and it gives you a great augment. But there are issues with it that has led to its abandonment. And then autologous tissue, which here we're talking about tissue engineering, and that is certainly not something that's a current option. So what's auto augmentation? Just to be complete, it's basically incising the detrusor and making a very large diverticulum, essentially. Well, fibrosis is really what happens. And so how about a ureterocystoplasty? Well, this is a patient that has, say, a non-functioning or poorly functioning kidney, for whom you're going to do a nephrectomy. Well, you have this very dilated ureter, and that can be fashioned into a patch and then sewn onto the bladder. Again, very, very rare that you'll have the perfect circumstances to allow this, but if so, it's wonderful. This is the ileocystoplasty, which again is the most common. We're going to take a basically 20 centimeter or so segment of ilium, which is at least 15 centimeters from the ileocecal junction. We're going to fashion it into a U shape, open it on its anti-mesenteric border, and then make it into this patch, basically, which then is folded over. The bladder is open in a clamshell fashion. One of my mentors, Dr. Stuart Bauer, used to open the bladder and make basically X incision, so open longitudinally and transversely, and make 4 leaves, and to really try to defunctionalize the bladder. I have not done that. I have generally just opened it very widely like a clamshell, essentially leaving just the trigone intact, and then sewing on this patch for the augmentation. These are very, very old data, actually from Stu Bauer from the 80s, when they looked at the contractility of the segments used for augmentation cystoplasty. And basically, ilium is mostly areflexic. It does have some contractions in some patients, but you can see the sigmoid is quite contractile. Fewer than 40% of patients have a non-contractile sigmoid augment. So it tends to squeeze quite a bit. It also makes a lot of mucus. This is the gastrocystoplasty from the greater curvature of the stomach, typically based on the right epiploic artery, gastropropylic artery. Again, great tissue, but not something that we do anymore. And I provide it here for just really historical reference. So when people talk about a gastrocystoplasty, you know what they got. And there are still patients that come in that have had this done, that are either getting screened for cancer or have other complications related to this. So something that certainly we need to know about, even if we're not doing anymore. This is the SCLU, seromuscular cholecystoplasty lined with urothelium. I've seen 2 patients that had this operation elsewhere. I've taken both down and given them a full augmentation ileocystoplasty because of failure due to fibrosis. This, I think, is a terrific idea, and it's just too bad it doesn't work, but it doesn't. And what happens is basically you remove the detrusor segment, So it's kind of like the auto augmentation, but it's not just incision, it's actually removal. And you leave this mucosa intact. I would say in a neurogenic bladder, that's easier said than done. When you do a reimplantation into a neurogenic bladder, it can be tough to make that tunnel and keep the mucosa intact. So this is a pretty picture, but boy, that would be pretty hard. And then you get a sigmoid colon segment from which you remove the mucosa and then sew that muscular segment onto the bladder. Sounds like a brilliant idea. Again, really, really interesting, but not been widely successful. So do we need a better option? We absolutely need a better option. A lot of the surgical complication data come from Indiana. We had Mark Kane as our visiting professor last year, who was absolutely wonderful and really presented their up-to-date data on the complications of augmentation cystoplasty. And they're absolutely not trivial. The overall prevalence of patients requiring surgery after having their augmentation cystoplasty is 34%, incredibly high. There is a mean of 1.5 operations at the bladder level per patient following augmentation cystoplasty, and a 0.8% mortality when you take into account malignancy and then death from complications related to perforation. So these are data that really should inform a very careful discussion with a family in a patient, so they're aware what they're getting. And we are really reserving augmentation cystoplasty these days for absolute medical failures, patients that absolutely need this, failing Mirabegron, so on and so forth, overnight catheter drainage, many maneuvers that can be done. So we do need a better option. And so more specifically, bowel obstruction, 3 to 11%, 6 times as high in gastrocystoplasty, if you can believe it. Secondary augmentation, almost 10% at 7.5 years out. The lowest rate is using the ileum, though. Ileum is the best, the most durable. Spontaneous perforation, 6 to 13%. Again, malignancy, 0.5 to 5%, poorly understood. But boy, the spectrum of malignancy it looms large these days. Of those with malignancies, 75% will have adenocarcinoma and 25% have others, including transitional cell carcinoma. Disturbingly, there's a latency to developing cancer, and that's 22 to 26 years. So these happen really far out. And there's a question if gastric segments are at highest risk. I was at I guess it was probably an AAP, I don't know how many years ago it was now, 12, 13, 14 years ago, when Rafael Gonsalves called for a moratorium on gastric cystoplasty. And this was why. So that was really the beginning of us taking a really hard look at this, and really quite readily led to abandonment, essentially, of gastrocystoplasty. So going on with complications, again, quite sobering. Bowel dysfunction, 10 to 54%. And then complications due to secretion, hematuria dysuria syndrome, and specifically those patients with gastrocystoplasty. Mucus production is significant, especially when you use colon. These are patients that have to irrigate their bladders every single day, sometimes twice a day if they're making a lot of mucus, which can lead to infections and stones. And then chronic urinary tract infections, 23%, some of which involve the kidney level. So recurrent pyelonephritis, 14%. So I have to go fairly quickly now, but for patients that require improved outlet resistance, we generally don't do anything if the outlet resistance is greater than 70 centimeters of water. For those with low outlet resistance, we consider a fascial sling. But we have to remember that an intact bladder neck does provide a pop-off mechanism for the bladder, so it's a safety valve, and also alternative access to the bladder if a patient needs to have their bladder catheterized. We do bladder neck closure as an absolute last resort. I really try not to do that. I hate to lose the ready access to the bladder neck. We do it when we need to, but again, I try not to. So the sling can be done with rectus fascia or SIS. I've done a few mid-urethral slings in older patients, older women with relatively milder incontinence. You can do bladder neck bulking agent injection. We do put a few artificial urinary sphincters in. It used to be a handful per year. Now it's maybe 1 or 2 per year. We've done the last few using robotic assistance, in fact, completely robotically, and those have been great. And so we do use artificial sphincter around the bladder neck, or in girls and in prepubescent boys, or in boys that are post-adolescent around the bulbar urethra like it's intended to be placed. Bladder neck reconstruction and bladder neck closure are the other options. Bulking agents, this is just basically a table from a current opinion and essentially lousy results. 50% at best for any kind of success, and a lot of injections. So 17 to 40% actually, very, very low. Rectus fascial sling is probably our preferred. We harvest this piece of rectus fascia and then swing it around the bladder neck. I actually like SIS better, just so I don't have to maybe get the rectus fascia. I've had good success with it. And then this is the wrap that we do, and this is the SIS sling. Success rates 40 to 90%. There are lower success rates in boys, and we certainly have experienced that as well. In boys, I'll quote as low as, as high as 50%, best case. This is the AUS, again, in girls or in women, placed around the bladder neck, and the pump is placed in the labia majora. In prepubescent boys, also placed around the bladder neck. In adolescent boys, we place it around the bulbar urethra. How about patients that need help catheterizing? So we give them an appendicovesicostomy or Monti-Yang iliovesicostomy. This is the Mitrofanoff principle as described by Dr. Mitrofanoff himself in 1980, a narrow sepal continent conduit connected to a large capacity, low pressure reservoir via a submucosal tunnel, which is brought to the skin as a catheterizable stoma. I love doing these operations. I think this is just amazing, the difference maker this makes for kids and for families that have to catheterize, especially wheelchair dependent patients who no longer have to transfer. So this is the appendix removed from the cecum. I used a stapler for all of this. This stapler picture, though, illustrates extension of the appendix. If this is too short, you can extend it onto the cecum. After you put a catheter in here, staple across it, and you get a much longer usable channel. And I implant these extravesically. Basically, I make a detrusor tunnel just like you would for a ureteral reimplantation, and I put all of these in invariably extravesically, even when I do a simultaneous augmentation cystoplasty. In patients that don't have an appendix, or someone has used the appendix for a Malone, for example, we can make a conduit, a catheterizable channel out of a 2 centimeter segment of ileum. And you can see here the cartoons on how that is done. This works great. In our hands, incontinence rates from the stoma are much higher. Near a third of cases will need a revision, whereas only 3 to 5% of our appendices leak. So if we can help it, we don't like making Montes just because they tend to leak later. Interestingly, not because our tunnel fouls, but these somehow, for some reason, get wide. They end up looking just like the piece of ileum upon which they were based. And so we make a nice little stoma in the umbilicus or where it reaches, and a V flap really is what we do, and I think just about everybody else, to limit the rates of stomal stenosis. So wrapping this up, hopefully leaving time for some questions. Spina bifida is the most common permanently disabling birth defect. It is the most common cause of pediatric neurogenic bladder. Children with neurogenic bladder require thorough evaluation, management, and lifelong follow-up. A multidisciplinary team is absolutely essential for these complex kids and families. Anticholinergic therapy and intermittent catheterization are the cornerstones of management. The preservation of renal function is paramount. That's priority 1, 2, and 3. And then for patients that fail medical management, we have an armamentarium of surgical options for improving storage, for helping with continence, and then for helping patients empty more efficiently and effectively. Thank you very much. And if you would please scan this QR code and leave a survey for the PedsUroFLO team, that would be much appreciated. And now I'll start looking at, looks like the Q&A session is open. And so I'll go through these one by one. What is the experience of Boston and fetal closure procedures? This is a fantastic question. We are not doing fetal closures at Boston Children's yet. We will hopefully be doing so in the next year or two. We're actually building a fetal team, hiring and recruiting a fetal surgeon, so on and so forth. So our experience is limited to following patients in our spina bifida center that come having had been closed as a fetus elsewhere. And currently we have about 30 to 35 patients with that history. And we have studied this patient cohort twice. And what we have found is that the lower urinary tract function is identical to patients with their lesions that were closed postnatally. So even if they have fewer VP shunts, which they do, and even if they ambulate better, which they do, their lower urinary tract and bowel function, by the way, appears to be equivalent. So you can't be fooled by a patient's appearance, whether they're closed prenatally or postnatally. Their bladders, their urinary tract has to be approached the exact same way. And we feel, very strongly about that. The second question is, do you use needle electrodes in patients with full perineal sensation, for example, a CP patient? Great question. Yes, we do. If for younger patients who are fully sensate, we will numb superficially with EMLA, although we don't have to do it very often. Surprisingly, I know it's easy for me to say, is what you're thinking, but patients have a slight pinch and then it's over. So it's very well tolerated, shockingly well tolerated, I will say. And so it's rare that we do EMLA, but for the patients that are fully sensate that are having a hard time, we will do that. The other parameter that our neurologist uses is perineal sensation. So when the needle is placed, do they have the appropriate response? And so that is a data point that he actually collects if the area is not anesthetized. Next is, can you please elaborate on the dose of anticholinergic that you use? Our first line is oxybutynin. Ditropan is the trade name. And generally speaking, I try to keep the dose as low. I and my partner, Aaron McNamara in the center here, try to keep the doses as low as possible. And that's to limit adverse effects of any medication, but certainly anticholinergics. So in babies, what we have done over the years is we have given 0.1 milligram per month of life. So in a 3-month-old, they're getting 0.3 milligrams. In an 8-month-old, they're getting 0.8 milligrams. And we stop at 1 milligram, and we generally start twice a day. So 0.3 in a 3-month-old twice a day, 0.8 in an 8-month-old twice a day, 1 milligram in a 10-month-old twice a day, and we stop at 1. So a 14-month-old will still get 1. And we're doing urodynamics every 6 months and then adjusting the doses appropriately. So we generally use that in the first, say, year of life is pretty effective. And then from there, we either use the recommended dosing per weight or just hold the lowest dose possible. Next question is, do we use solifenacin? Yes, we actually have. We have used every anticholinergic that is essentially available. We are limited by what insurance companies cover for patients. And we generally have to then, for most of our patients anyway, we have to start with the least expensive formulations. So things like oxybutynin or tolterodine, and then make a justification for going to other versions. I will say parenthetically, we haven't studied it rigorously, so but anecdotally, just based on how it's promoted, I generally do like to use trospium. And I like to use trospium because it's a quaternary amine that doesn't readily cross the blood-brain barrier. And so at least theoretically you have fewer adverse effects that are central nervous system related. Parents these days, understandably, are more concerned than ever about cognitive function and the impacts of such medications on cognitive function. And how can you blame them? You have children that are already disadvantaged intellectually, and then even the possibility that a medication is compounding that is of concern. So I do try to use trospium as much as I can, understanding that we repeat urodynamics to check efficacy and still be on the lookout for adverse effects. To which group of patients do you use artificial sphincters and slings? Well, so as a larger group, of course, we're talking about patients that need help with outlet resistance. So these are patients with very low leak point pressures. And so these are patients in whom their bladder dynamics are optimized. So you don't think it's a reservoir issue. So it's a low pressure bladder. Capacity seems to be reasonable. It's an outlet resistance issue. And those are the patients in whom we choose an AUS or a sling. Now, the decision as to which one to use comes down to the specific patient and after discussion of the risks and benefits. I will say that slings, we don't offer slings to boys very often at all. We just don't like the high failure rates, and technically, it's not the easiest procedure I have found to put a sling around the bladder neck, especially in a child with a neurogenic bladder. And happy to do them if the success rates were acceptable, but for the low success rates in boys, I don't like to use them. So we do prefer AUS, actually. Probably from an outlet resistance perspective, AUS is our preferred surgery. We've done them as young as children who are, say, 8 or 9 years old around the bladder neck, and of course as old as we're allowed here at Children's Hospital, which is 34, if you can believe that. So AUS is really our preferred if I had to pick one. Next question is, do you implant the appendix anterior or posterior on the bladder, and why, please? So I tend to put it more anterior than posterior, but quite lateral. And so I guess my answer is sort of in between. And the reason for that is what I want to avoid is the patient traumatizing their bladder on the way in. I want to give that catheter enough space that when it goes in, it'll go in comfortably and won't bang into the base of the bladder immediately. So I don't like an angle coming in from anterior going directly down. I also don't like posterior, where the catheter is going to go right in and hit the trigone almost on a parallel fashion. So I try to put it in a place that I can see it'll go comfortably into the bladder and not traumatize the bladder. And so I would say it's in between those two, perhaps more anterior than posterior, though. The next question is, what is our experience with Botox? Interestingly, we don't do a lot of Botox in younger kids, but in older patients, just like the patients for whom it is FDA approved, we've had great success. So these are adolescent and young adults with NDO, so neurogenic detrusor overactivity, who either are unresponsive to anticholinergic or are having side effects to anticholinergics, or just want to try to get off medication. And in those patients, Botox has worked well in our hands. We use the same dose that everybody else uses, and so up to 300 units as our top. I inject these in a very random pattern, sort of starry sky pattern throughout the bladder. And so we don't have a huge experience with this, but probably I would say we've injected over the years 30 to 40 patients. So it's not a huge number at all, but that's my experience. And let's see if any other questions are coming in. I think we just have a handful of minutes left, just literally 2 minutes. I think I've answered all of the questions that we have. I'll wait just a few more seconds and see if anything else comes in. I wish I could see the audience and interact. Of course, we're limited to the Zoom life that we have, but thank you very much. And I think that concludes our session this evening. And once again, I want to thank the organizers and Dr. Hillary Kopp specifically for asking me to do this. It's really a delight. Hillary, I wish I could see you in person, but I hopefully will do so soon. And if anyone has any questions or if I can be of any help, just email me, carlos.estrada@childrens.harvard.edu. I'd be happy to answer any questions or collaborate or anything else people have in mind. Again, thank you very much, and stay safe, and please vote. And that's it.